Hi everyone, this is John Mandrola, Heart.org, Medscape Cardiology, and I'm here in Madrid, Spain at the ESC meeting, and I have a friend, Prash Sanders, who is a full professor and luminary in EP. He's at the University of Adelaide, and he presented in the late-breaking science a trial called CAAN-AF, and this is a trial dealing with one of the things that we don't often talk about in the AFib community, and that is AV node ablation. And so I was really excited to hear the results of this trial. So Prash, tell us about the trial.
This is a trial that looks at patients who have CRT-D devices and permanent atrial fibrillation. And the question is, should we be medically rate controlling them, or should we undertake an AV node ablation? And there's some data to say that patients, if you ablate the AV node, do better. And these are observational data. So here's a randomized study, 1-to-1 randomization of patients to medical rate control or to AV node ablation, and we found no difference over a 2-year period on a composite endpoint of all-cause mortality and non-fatal heart failure events. So that's a big deal because our current guidelines actually say that we should be considering AV node ablation in anyone who's not pacing more than 95% bi-ventricularly. And this argues that that shouldn't be an empirical decision for us to be making.
This is a remarkable finding because it's a trial that found no difference, so a negative trial that disrupts the guidelines.
Yeah.
And it's usually the other way around, right? It's usually a positive trial disrupting guidelines. But this is the beautiful thing about evidence, is evidence is evidence. It doesn't matter how it comes out. Just for the audience, these CRT devices, CRT, cardiac resynchronization therapy, bi-ventricular pacing usually. The idea is that if you're going to resynchronize the heart with pacing, the device has to pace all the time. The more it paces, the more the benefit. And if the patient's in atrial fibrillation, oftentimes the rate is higher than the paced rate, and then if they're conducting with that ugly left bundle branch block, they're not getting benefit from the device.
That was our conventional thinking.
So there's two ways to make this device pace. One is to lower the rate with medications, or to ablate the AV node, and then patients often with an AV node ablation have a decreased medication burden.
Yep.
In real life, when we do AV node ablation and someone has a very high AFib rate and we pace, we usually can take them off their medications and they get dramatically better. So I went to your presentation thinking that this would be a highly positive trial because my experience and your observational data suggests that AV node ablation is really a remarkable thing to do for these patients.
Totally. Look, so actually the observational data would suggest that ablating the AV node improves these patients' mortality by 58%. That's dramatic. An all-cause mortality improvement, driven mainly by cardiovascular mortality. So we went into this study expecting a positive result from this study. With that 58% mortality benefit, you actually needed only a small study. Okay, so when we planned this study, although we used a composite endpoint, not just all-cause mortality, we also assumed only a 25% reduction rather than a 58% reduction. And so we gave ourselves some space, but we did allow ourselves an interim analysis at every quarter of recruitment.
Well, let me ask you about that interim analysis. Did you do the interim analysis because you were afraid it would be positive and you thought you would be terminating early?
That's exactly why. So we pre-specified that we would look at the data because we fully expected this to be a positive result by the first quarter of patients.
The guidelines say that if a CRT device is not pacing, 90% or more?
90 to 95%.
They recommend
AV junction ablation.
Is it a level 1 recommendation?
It's a level 2A with a B non-randomized level of evidence.
So a very strong push, and 90% bi-V pacing, that's pretty strict number.
Very strict number. And important, in this population we studied, At baseline, it was 74% pacing in both groups when we monitor them by Holter monitoring to determine biventricular pacing amount. So this would fit into that criteria where AV node ablation would have had to have a benefit.
If they were 74% bi-V pacing, you're well under the 90%.
Totally.
Then what happened?
We did the analysis, and to our surprise, the event rates were almost identical. And so this was presented to the Data Safety Monitoring Board, who actually said, well, it's time for us to do a futility analysis on this. And so we did a futility analysis, and it really showed that there was a 2.7% chance of us finding a difference with full recruitment. And that means 97% chance that we will never find a difference. So I think that's kind of important. There's a few points to kind of recognize. We used an event rate from the companion trial, which was 50 events per 100 years of monitoring. Our incidence was actually 34. Basically, since the companion study, what's happened is our medical therapy has got a lot better. And so the event rate has reduced significantly. And if we now redo the power analysis, you need about 4,300 patients per arm. And as I mentioned in my presentation, if you then look at that in terms of futility, based on the difference in the event rate between the two groups, you still had an 83% chance of being a futile study, despite that large number. So this is fairly definitive in terms of saying there is no difference between these two treatment arms for the population of patients with permanent atrial fibrillation and having CRT.
I noticed from your presentation that, okay, so 74% bi-V pacing, we would get pretty excited. I would certainly get a message from our pacing center if a patient with a CRT was only bi-V pacing 74%. I would worry about that. But I also noticed that in the trial, your heart rates were not very elevated.
That is a baseline heart rate. So when they come in for their resting first visit, their heart rates were 72 in both groups. So that was actually pretty good rate control at baseline. During the course of the study, with medical rate control and with AV node ablation, so AV node ablation, the bi-V pacing increased to 98%, which is what we'd like to see. Medical rate control increased to 89%. Okay, so there was a significant difference in the true biventricular pacing that these patients achieved. But despite that, we didn't see the translation in any change in event rates.
This maybe should change our thinking about what the best number or reasonable number of bi-V pacing percentage would be. Maybe we don't have to have 90 to 95%. Maybe 89, maybe 85, maybe something along those lines is fine.
We really have to look at it on a case-by-case basis, as opposed to saying everyone should be receiving AV junction ablation. So I think that's what the message of the paper's got to be, and it really should not be that guideline recommendation at such a high percentage.
So really important clinical trial that comes up showing no difference, and I think should change guidelines, and it should change our thinking about what we're aiming for with bi-V pacing.
We have enough evidence here to say we need to change the way we're thinking, and sometimes you get these in trials. You know, it certainly was a surprise to us. It was unexpected, but that's why we do trials.
Excellent. Prash, thanks for talking with us. I really appreciate it.
Thanks, John.